Multinodular goiter, which is also called multinodular hyperplasia or adenomatous hyperplasia of the thyroid gland, is multinodular transformation of the thyroid gland parenchyma, which is usually asymmetric, and it is associated with enlargement of the thyroid gland. The etiology is multifactorial. The process is associated with follicular epithelial hyperplasia, which could be caused by impaired thyroid hormone production, or it could be associated with increased thyroid stimulating hormone secretion. Under the microscope, we typically see multiple nodules. Sometimes we can find the areas of fibrosis. The follicles are typically not uniform. Some of them are enlarged. Well, we usually do not see these really large follicles in the normal thyroid gland. However, sometimes some nodules can be associated with really small follicles. So here in the center we can see microfollicular adenomatoid nodule. All of these follicles are lined by normal thyrocytes, and inside of the follicles we see colloid content, which is this proteinaceous amorphous material. The thyrocytes can be flattened or cuboidal or cylindric, and here we see these bubbles in the colloid, which means that these thyrocytes are more active than these flattened thyrocytes. Nuclei are uniform. They are not enlarged. They can have inconspicuous nucleoli. However, we do not see nuclear enlargement, nuclear clefts, overlapping of the nuclei, or clearing of the chromatin, which would be a morphological sign of papillary carcinoma of the thyroid gland. We do not see thick capsule around these adenomatoid nodules. However, sometimes we can see some fibrosis and something that looks like pseudocapsule around some of these nodules, for example here. But the overall context helps us to differentiate follicular adenoma from the multinodular hyperplasia. Follicular adenoma is usually solitary, and it is distinctive single nodule in the thyroid gland. Multinodular hyperplasia is very common. It can be associated with iodine deficiency, which could be amplified by tobacco smoking. Sometimes it can be associated with consumption of goitrogenic food, as broccoli or Brussels sprouts. Sometimes it could be caused by medication, and the genetic predisposition also plays a role. So in most of the cases, the primary cause is not really clear. The pathogenesis of at least some cases can be explained by impaired thyroid hormone production, which is then associated with increased secretion of TSH, and that drives the proliferation of the epithelium, and that leads to nodular transformation. Some of the thyrocytes are more responsible to the TSH, some of them are less responsible to the TSH. So that's why we see variable multiple nodules. Some of the adenomatoid nodules can even become TSH independent, and then they grow even without a TSH stimulation. Multinodular hyperplasia is much more common among women, and it usually affects women in their 50s or 60s. Most of the patients are euthyroid, and they have clinically no symptoms of hyperfunction or hypofunction of the thyroid gland. The process usually starts as mild thyroid gland hyperplasia, which then can become nodular over the time. And some of these larger nodules can be autonomous, so clinically we can typically find normal levels of TSH, T4 and T3, or sometimes we can see normal T4 and T3 and low levels of TSH. Thanks for watching.